brief. So I will, and he can fill in anything else that he thinks is pertinent for you to know. But Dr. Thomas is Director of Telemedicine at Children's Hospital. He's also the Executive Director of ECHO Colorado, which we're going to hear about. Dr. Thomas has a PhD in psychiatric epidemiology from Texas. He also has many affiliations throughout the campus, including in our Department of Epidemiology, pediatrics, family medicine, psychiatry, nursing, and social work. What I hope he will also comment on is his membership. He's a life member, actually, in the Texas Exes Association. So eager to hear a little bit about that. Here he is, Dr. Thomas.
Thank you. The Texas Exes thing is not a high bar, actually, so maybe I won't talk about that. I appreciate you all coming, and I apologize. I'm a bit of an awkward speaker, and do have Marco Rubio moments here and there where I'll leave the stage and go drink water or do something like that. So be patient with me. So what we wanted to talk about today is ECHO Colorado, and I was either invited or co-opted or connived or something by Don to come give a talk about ECHO. And I think it was twofold. It was a little bit to talk about what some other people that have appointments in the department are doing around campus and what they're doing around the state. But it also is an idea to kind of give some of you the idea about what is going on from a virtual perspective around the campus and how the campus is involved in that work, both from how it's delivering things from campus out, but how we're also partnered with other entities around the state and around the nation. So, as we mentioned, I am an associate professor in the school or the Department of Epidemiology, and I'm an associate professor in the School of Medicine. And so when I came to campus 7 years ago, there's a lot of different people that were trying to figure out how they might use me or whether they would use me and where I would sit. And so when I came, I was originally hired by the School of Medicine to figure out telemedicine related things. And then very early on, within the next year or so, we actually had applied for the ECHO work to start integrating ECHO. And actually, I was hired by the Department of Psychiatry to do their tele-related work. And then very shortly after that, Children's Hospital said, we need to do all of this stuff too. So how about we figure out how we pay for part of you and adopt you and make you become the Director of Telemedicine for Children's. And so we won't talk about children's tele aspects because there's 100 of them or so relative to things that we do around the state and around the region from a 7-state region. Telehealth from that perspective is much more the idea of the traditional telehealth model of a interaction between one provider and one patient, or one provider and a group of patients, and it's less so the consult model. Or as we're kind of talking about how ECHO and eConsult come together, peer-centered, peer-mentored care delivery. You're liking it, right? Okay, it's all good. It's brand new. So and I'll go back, sorry, from the ECHO perspective, if you're thinking about telehealth, telehealth again is that one patient, one provider, something like that, generally the idea of how you provide care remotely. And the ECHO idea started in New Mexico about 13 or 14 years ago with a hepatologist who had recognized that a bunch of folks were showing up in Albuquerque with hepatitis C or liver cancer related kind of things, and thinking, could we do something differently for the people in Las Cruces, Las Vegas, et cetera, so that we connect to those providers, those primary care people that are giving care out there in the remote areas of the state, and help them deliver evidence-based care remotely and prevent some of this work that ends up at the University of New Mexico. And so in 2014, thereabouts, they published the ECHO seminal article, I guess, which was basically in the New England Journal of Medicine that said care remotely, and that model was as good as care given at the academic medical center. And then so from that point on, ECHO just sort of exploded in a good way. So at this point, I think there are 181 echoes around the country, around the world. Echoes in 30-something countries, I think. Every Department of the Defense uses echo, and if you will, if you think about where there's capitated care models or value-based care model delivery, the idea about how you could do something in a way to keep costs lower and demonstrate an outcome that is as good or better, but to keep costs low, is where echo is used a lot. So you find it in the Department of Defense, the VA, all those places use a lot of echo around the country. We are at this point, I think, or have been, as of there's an ECHO Act that was written a few years ago and a report to Congress last year. And I do believe that we're the largest ECHO, if we're not the second largest ECHO compared to New Mexico relative to the number of things that we're offering. You see, it was lovely to see this report to Congress where there were any number of states that were doing a certain number of echoes, the standard ones that they had gone to New Mexico to learn about, and then Echo Colorado, which kind of shot up relative to the number of offerings compared to the other states where we were offering multiples compared to the other states. So again, thinking about how Echo or the model is using technology to deliver care or to deliver care management or to deliver consult or to deliver the ability to provide something locally with the expertise from an academic medical campus. And so, if you will, moving knowledge instead of moving people. So the idea that you could do something remotely, but through the use of through technology. And any of these are things to think about relative to different models that we're thinking about. So in Colorado, we spent about a year prior to the actual grant money that we got for developing ECHO. We got a little planning grant from the Colorado Health Foundation to grow around the state for a year and to ask traditional providers, communities, different entities around the state, what's your relationship with the university, with Children's, related to access to care, related to how many patients you send, good, bad, otherwise. And do you know have you heard the good word about ECHO? And if ECHO was developed in Colorado, what would it look like here? And would you use it? And so that year of interviews informed us a great deal relative to what ECHO would look like in Colorado. And so the other models, generally, somebody from a state would hear about ECHO, read the New England Journal paper, and probably send someone, an academic faculty person, to New Mexico to learn about it. They drink a good gallon of Kool-Aid about it, and then they go back to New Mexico, or go back to their state and go, people, you don't know what I've heard. Let me show you what I've heard, and let's see how we integrate it into our clinical care model. Or the problem with that is there's no reimbursement. There would be no sort of scaling of that. There'd be no integrating it into the current models related to funding or reimbursement. And so a lot of those things sort of stay in one faculty division, or they die off. And what we wanted to do is to actually build something that was much more integrated into the campus and think about how it would benefit the state. So one thing from our original Colorado Health Foundation money was they wanted a real emphasis on rural and how is care delivered in a rural areas of the state, which there are a lot of them. And if you move away from I-25, you're in rural Colorado, frankly, unless you're from Grand Junction, and I apologize to you, but there's largely I-25 corridor and the rest of the state. And so what this actually bar graph is meant to represent is the idea that over and above the great rural discrepancy in Colorado related to populations and access to care, we've actually overperformed or we focus more on rural than even the demographics make up for the state. So this is a small list because it's not 77 of them, but we have done, I think, 77 different topics as of this date. Mike, am I correct? So 70 give or take, 75 give or take, however many. But that's probably more by a multiple of 3 or 4 than any other state's ECHO related to the topics. And you also see the great diversity of topics. So it's not just adult medicine topics. It's also pediatric related medicine topics. It's also public health related things that we have a great partnership with the Rocky Mountain Public Health Training Center to do some of their work. So you'll see things related to foodborne outbreak and work with communities to think about that. So if you thought about it from an ECHO model, if you're thinking about the delivery of endocrinology care or diabetes management, it makes a whole lot of sense if you have a well-managed diabetic who is maybe not going to their clinician as many times or coming to the academic medical center as many times and having some of their visits managed by a primary care doctor locally. If you're thinking about a foodborne outbreak sort of thing, who are your experts? How's that brought together, and how do you sort of do that sort of thing? So the case presentation relative to a disease scenario in a patient would be different in a public health related thing where you had a different set of a public health or a town's public health entity or someone presenting, here's what we did, here's a challenge we face, and any number of people presenting challenges like that and a group of experts giving them feedback about how to manage it. Does that make sense? You had nods. So if you saw something up here and you thought, well, holy crud, I'd like to know what that looks like or how you did that, or you have particular research interests or thoughts about what you would like to do or groups that you're working with, please do ask questions about any of these or why you haven't done blank, and we'd try to talk about that. So as I mentioned, the Colorado model is a little different than the other states that have done ECHO. And that was also done relative to, if you know the term, the town gown issue relative to, oftentimes the University of Colorado might have a relationship with a community, but what the community hears when someone from CU comes out to say, we're here to help, is they hear, we're here to tell you what you've done wrong and how to make it better and make it look more like what we would do at CU. And so what our perspective was much more about, how do we partner in a way that actually builds this relationship with community-based organizations so that we're in this together. The idea that you have a need, we have capacity, we're not going to replace what you've done, but augment what you've done to actually make the model work better for both. So you can see in this little, these are things called, I think we've called them flux capacitors, which is I never saw Star Wars because I was still in that gap group of years. Oh, it was? Okay, that's it. I never saw that either. But that range of, right, it was not Star Wars. But we have several flux capacitors that show how these sort of work. But and the other piece that was unique to Colorado's model is it was not CU-centric, CU out, but we also formed a statewide board of directors that represents different communities to basically feed back to us the ideas that they think should happen in those communities. The other idea too is for you all who have gotten grants and gotten lots of grants, is it's painful when they go away. So the idea about how you bridge your funding and also have braided funding to sort of bring together billing and grants and contracts, all of those sort of things, so you're not dependent upon going and chasing philanthropic dollars every few years, even though we will chase those. The other idea, which was unique to ours, was as we got our money from the Colorado Health Foundation and from others, we actually created relationships with other organizations that were statewide to say, basically, you do something that we both agree, we think, matches with how ECHO could work with you to make what you do better. And thus, we're going to take some of our money and we're going to give you some of that philanthropic money to go out and do what you do through the use of ECHO. And so it really does sort of prime the pump a little bit, if you will, relative to giving someone money to actually have them use it for spending on the efforts that are collaborative with you. And so it's just a bad analogy or metaphor, whatever it is, but our medical director calls this our drug dealer model, which is, we're going to give you that first one free. And so, but he always does it with that little hand slide across the table, which I think some people like, some people think it's less attractive. But anyway, it's sort of like, we'll give you this and see if it gets started up. And then at some point, you're going to love Echo so much that you're going to continue to do this and find your own money. Sometimes it works, sometimes it doesn't. So I wonder if I can play from here. Let's see. So as we've moved away from just thinking about Echo in a by itself, and telehealth kind of being by itself, and e-consult and all the different mechanisms that are e-related things being sort of separate lanes of traffic, the thing that made most sense for me relative to being a telehealth oriented person when I came here was how you meld those together in a model that sort of demonstrates the ability of using the right tool at the right place with the right partner. Sometimes it may be Echo for co-management, sometimes it may be direct telehealth, sometimes it may be an e-consult effort, sometimes it may be a combination of three. And so as I went around the state and drew pictures on boards or had little napkins that I had drawn a diagram on and lost them or left them places, we had a very talented marketing staff who put together a video on YouTube. And if it doesn't show, I'm not going to be way too embarrassed because it doesn't show sometimes. But you could go to YouTube, look up Echo Colorado, and you can see basically everything that was in my head condensed down to 1 minute and 52 seconds, which is maybe not so hard to do, but there you go. Let's see if it comes up. It may not have the volume though.
There are many inefficiencies in the healthcare system. For a patient needing healthcare, these inefficiencies can create unnecessary treatment barriers for patients, diminishing their experience and negatively affecting their health outcomes. At Echo, we see this as an opportunity for improvement. We connect health professionals from different communities with a variety of knowledge and breadth of experience and allow them to share best practices and resources to improve the quality and efficiency of healthcare. Echo, one part of a bigger practice paradigm. Together, we want to make the inefficient efficient. With coordinated care, a decreased need for in-person appointments, and an improvement in overall healthcare value. By empowering the integration of the practice paradigm into the patient-centered medical home and medical neighborhood, we can optimize talent, techniques, and technology. Shared knowledge from specialists and experts creates opportunities for other providers and staff to practice at the top of their ability, increase capacity, and efficiently manage complex care. With your help, we can institute a new, efficient practice paradigm that optimizes patient experience and outcomes, lowers the per capita cost of healthcare, and improves the work life of our tireless healthcare providers. Knowledge held by one has the power to change lives. Knowledge shared by many has the power to change the world. A better life for patients and providers starts here. Let's Echo.
Usually wild applause, but I'll not have you all have to do that this time. So I'll tell you that I, after drawing this stuff and kind of thinking about this related to being more of a social entrepreneurial kind of techie person, and actually having a staff member who's listening to all your verbiage and actually goes through and actually puts that together, I turned and cried. I mean, it was just like this moment where they completely captured what I was trying to put out. And this is one too that for the people that go to the, there's a thing, I know you'll have it on your calendar by the end of the day, but Meta Echo. It sounds like, a godsend, right? Oh, anyway. So Meta Echo is when all the people converge on Albuquerque that are doing echoes around the country and around the world, and everyone comes to New Mexico to share what they're doing. And frankly, in some of the internationally, some of the most exciting things are going on relative to managing chronic diseases that it would just sort of knock your socks off. There are some exciting things happening in the United States, but still, what happens related to healthcare, what happens related to the healthcare system, what happens related to the Accountable Care Act, all of those things sort of weigh in relative to whether or not funding comes federal or state relative to doing these sort of things. We frankly feel quite good where we're positioned because from a let's say a progressive perspective, the idea of expanding access to care and providing local care and partnership with primary care providers, more driven by people who know about social determinants of health, et cetera, it makes sense. The other side of the spectrum would be if you're thinking from if the Great Orange One becomes president, again, that it'll all be about cost cutting. It'll all be about Medicaid block grants. It'll all be about those sort of things relative to reducing expenses. And so we feel quite confident the ability to speak either language. And so we feel all right with that. So here is the origin, frankly, of the origin is bad writing on a small napkin, but it developed there relative to how the spectrum of care happens. And I often use a type 1 or a diabetes sort of model to think this sort of way. That if you think from a traditional perspective of the ADA would say, if you're a type 1 diabetic, you should come to and see an endocrinologist 4 times a year. But frankly, that doesn't make sense. And then frankly, our medical system and our medical campus is a little bit codependent with certain patients, because a patient may live in, if anyone's from Craig, I apologize. Someone may live in Craig, and Craig's a lovely place, but you're not going to see an endocrinologist in Craig, and you're going to drive or fly to the academic medical center. And at some point, you come and you see one of our lovely people who are subspecialists, renowned, whatever, and you tell this person, it's like, I get such attention here. I love what you do. I want you to be my primary care doctor too. And unfortunately, a number of our providers will say, they have a hard time saying no. And so they say, yes, we'll do that. Wrong model. So the idea that we should be communicating, frankly, I think, would be as people get well and get better, to be communicating to them, as you get better, you see me less. You're going to be with your primary care doctor in Craig or whatever. I'll come in for one visit. So you think about the in-person care reduced to 1 or 2 times a year, with the second one coming in where you have the patient and their parent or the patient go to their primary care doctor. They present from there via telemedicine or from their home. And then that primary care doctor who's seeing more more diabetics, more asthmatics, more depression, all of those different things, is learning more, expanding their practice, doing more with less, not with less, but doing more and doing more locally. And so they're expanding to practice at a higher level of licensure. And then each time that they present in an echo, a case, it strengthens the capacity of all the other echo participants who are listening to similar cases, growing their knowledge network. And then in between that, if something comes up with the idea that I can't wait for the next scheduled echo, I really need a question answered right now, you could send an e-consult request to say, I'm about to do this, the script's going to change, there's been a new wrinkle in this, could I get feedback from you about what's going on with that, if I'm doing the right thing locally. And so I love this too, the accordion of care, if you will, so expanding, contracting, having the capacity to do what you need to do to both lower cost and improve outcomes. Does this make sense? Does anyone want to throw a bad piece of fruit at me at this point and say, you, Frank, are wrong, even though my name's Ray? No? Okay, so we'll keep going. So, as we've evolved, if you go and start looking for the groundbreaking research that's been done in echo, it'll be a pretty quick look because there's not a lot of groundbreaking research done in echo. And so what we're trying to do more of is to actually demonstrate the ability to show some amount of outcomes that are beyond the outcomes which are important, But when we've trained, let's say we've done depression and anxiety, management of psychiatric behavioral health for pediatric patients in primary care. Big need. Not a lot of psychiatrists out there, not a lot that live in Craig, et cetera. And so the idea about getting care via a behavioral health kind of topic in those settings is either your primary care doctor who had that, were exposed to that in medical school, but not as much as they maybe should. And then frankly, given the amount of time that they have to spend, or they are allowed to spend in an individual visit in order to keep the doors open, if you ask that question, you're going to have to deal with the answer. And so the idea about asking the question, do you have comorbid behavioral health things, will come with something of, okay, now I have to deal with that. And so the idea of training them to do more in their local community makes a whole lot of sense. And so what we've done thus far, we've done, I think, 7 or 5 or 6 or some number of cohorts of this training for private practitioners around the state. And what we have from evidence is that they like it. We know people like ECHO. What we have from evidence also is we know that from a statistical significance, we've actually changed their knowledge related to assessment, diagnosis, treatment, and management of behavioral health conditions, and related to those kind of clusters of activities and 5 or 6 different mental health things. All good and fine. But in this day and time and in this environment, what we need is more than that. What we need is we need to show that we've done all of that and we've saved money. And so what we're doing, the next step in that one would be that we've had these trainings. They're all Medicaid providers. We can go back and look at their prescribing patterns and their patterns with their panel for the year prior to their training. And we've done a training about a year ago, so we can go now and look at their training or their prescribing and practice after that with an actual pretty good matching of a group of non-exposed Medicaid providers, and then demonstrate whether or not through DUR data that we've actually reduced some of those important things. Real important topic, real important time to say that you can do this and you also can save money. Similar, so that's the third one. I skipped out. The other item that how these sort of come about is, as my role as the director of telemedicine in children's, one of the pulmonologists came to me and said, Denver Health pays 10% of my salary. I generally drive over there. I'm usually late. Parking's bad. I show up for my clinic and I'm already behind. They've shoved more people in my clinical space than I have time to see. And so nobody gets good care. Could we do something differently? And so Denver Health was one of the entities that we actually give some of our money to, or gave some of our philanthropic dollars to. And so we said, let's create a different model. And so Denver Health is a unique scenario in that they're lots of Medicaid. They have a very robust school-based health center system, 16 or 18 school-based health centers. They have their own medical record, and they have their own e-consult system. So they already have all this built in. Plus, all of these students who go to Denver Health as a patient also are in that school, and there's data related to their absences from school, all of that sort of, their grades, all of that sort of thing. So a very robust sort of system. While pediatric asthma is not a big spend from a Medicaid perspective per year overall in the overall scheme of things, it was something that was a low-hanging fruit that both Children's and and Denver Health could agree on. Because from a children's perspective, they don't want any Denver Health Medicaid kids in the emergency room because they lose money on every single one of them that are there. And from the Denver Health perspective, they don't want any of their kids in the emergency room because they spend too much at Children's for every patient that's there. So the idea about creating something different was a real opportunity. And so we used our money to pay for this pilot, and it's in the beginning of its second year. And the idea, frankly, is to have care as usual, which is, we'll say, a poo show, compared to, less than a poo show, it's moderately good. Compared to a model that you have Echo and eConsult in a set of clinics with the ability to basically have the clinical nurse practitioners that work at those schools to get more capacity to manage the kids that are at their schools locally, which would lower costs, which would create the care being done locally, compared to a direct telemedicine model in two locations with a direct patient model, looking at all the costs, looking at all the outcomes, comparing to those different sort of lanes of traffic. And in the next year, we should have some data to demonstrate whether or not, and I don't really care if it ends up being the telehealth model or the Echo eConsult, but I frankly think the Echo eConsult will come out to be the one that performs best, but we'll see. So what I'm trying to get at here is we're doing things innovatively to change the model of care delivery with particular partners that have some interest in also funded by Medicaid, also interested in reducing costs, also interested in changing models because they have a capitated model. Who of you know what UPL is? Okay, so UPL is upper payment limit. So it's money that flows from CMS through the state Medicaid to generally the School of Medicine in a state, because it's in effect CMS's request to have providers see more Medicaid patients in their state. And so because most states, the places that have the most specialty providers is the academic medical center, it flows to the academic medical center. So the Dean of Medicine sits on this pool of money to, in effect, incentivize the idea of creating new models of care and to do it in a way that reduce cost and have equal outcomes. And so we're written into any number of UPL efforts by individuals who frankly come to us or who write proposals with the idea of, we want to see more Medicaid patients, we want to do it less expensively, we want to demonstrate that we're using the tools. And so that's one of our funding mechanisms for how we help the state figure out how to spend less on providing care to Medicaid patients, but to do it locally and to do with equal outcomes. Similar thing, CORE is these are all things I hope you'll look up because they're really interesting models. But CORE, I have no idea what the acronym is, but it's something that probably goes with CO, Martin. Okay, never mind. So I know I didn't sleep last night. So I'm not Mrs. Maisel up here. You may know Mrs. Maisel. Okay. So, but CORE is an acronym for something or another that goes with those letters, and it was funded by by CMMI. Which is the Medicaid, Medicare Innovation DC-based effort. To basically, there's been 3 different cohorts. We're in the 3rd cohort, CU's in the 3rd cohort of figuring out how to use eConsult to make our delivery of medicine more efficient. And so it's an internal-based effort to focus on what are unnecessary visits that happen at the medical campus, how efficient is our eConsult mechanism that we do with community-based providers, because if that whole mechanism would be, if you know somebody who's a rheumatologist or who is a neurologist, those numbers are golden. And what generally will happen is, like if you're a primary care guy or gal, you have someone who shows up who has who's a child who has seizure disorder, and you don't want to know how to manage it there. You want to know Carolyn Green's phone number. And so, and that's what's happened, but it's very inefficient to work that way. So this whole system is built up with the idea of having organized templates that if you're going to ask me for a consult at CU, you have to fill out this information about the basics that you'd make a diagnosis with. So it has all the basic information, what medications they're on, what their problems are, other presenting sort of things. And then that helps the providers here answering those to answer them more efficiently. And so we're also built into, if you could imagine, as that eConsult system sort of spreads through the CU Health or CU Medicine enterprise, it comes with a great deal of big data. Who's performing efficiently, who's not performing efficiently, what is high value versus low value care, and the use of Echo could be, we have this group of providers who are sending referrals in or requests in like this, and we really need to educate them relative to doing this more efficiently and more effectively to do this high value care model. So I know I missed a few points there, but go look at CORE and the CMMI, and you'll get it. And we're a partner in that. And then obviously, the idea that if we're not involved in something related to opiates, because it's everyone's big problem, it would be an effective use of ECHO. So we're very engaged in some work, and we've been involved in one of the randomized control trials for MAT training, comparing primary care providers who done in person versus providers done via ECHO to see whether or not their prescribing differences are different by the mechanism. So sort of, and there's unfortunately a number of people from ECHO will say, okay, Fred, you touched the tip because you forever come in with an idea about we should go here or go there, and they shoot me with that gun that has the net on it and put me away for a while. So these are just sort of, I've said some of this stuff much more inefficiently, but these are, as you look at, it's like, oh, that's what he said, of how we're engaging, how these things come together. And again, if you are having to answer did he touch the points of quadruple aim, there's my slide that said I did. So, and the quadruple aim, you probably heard a lot about triple aim, which is better care, less cost, value, but it's also satisfaction. And the idea is not just the patient satisfaction, that they actually are okay with care being delivered that way, but the provider satisfaction relative to, I like this model. I like doing this sort of stuff. I like what I get out of it. I like what my patients experience from that. So it's important from both ends, because if you remember the slide before, one of the echoes that we've done quite a few of is resiliency, and that's with providers relative to who in the current system really struggle with burnout and worry about what happens to their ability to continue practicing this way. I think I covered that. And so that's our, using ECHO as a noun, using ECHO as a verb, which is kind of clever, right? And if you have an interest, we have a lovely website. Go see the different topics we've done, what topics are proposed. It's echocolorado.org. And you can see the staff and where we're aiming to go. And if you have research, or you're doing certain things that are partnerships or collaborations with folks around the state, and you think you'd like to tell them about this, we'd love to hear that sort of thing too. So that's that, and I'll take questions now. Oh, and that's, well, we need money. Okay, there you go. So any questions, thoughts, concerns? Yes, ma'am.
So back on the accordion of care slide, that one, where is that in between reality and aspiration? Is that aspirational except for a few specific examples?
I'd say your last part of that statement was correct. And so, except for a few examples. I mean, Medicare pays for e-consult and some piece, but then Medicare doesn't provide good reimbursement or steady reimbursement for telehealth itself per se. So it's sort of Red Sox on the third Thursday sort of things relative to, if you get my analogy of you just have to think about where you are on a given thing relative to whether or not this model works. We are engaged nationally with working on models, and this is frankly what these things are about, is to demonstrate to Medicaid we can do this, and we can do it, and we can do it in a efficient way, and with the problems that are most important to you. So I think there are forever things that float up through the Congress that say we'd love to know how we fund ECHO and e-consult and those different pieces. But then there's also a little bit of dialogue out there that okay, if you expand and you provide access to care for everyone and everyone via a television set or their phone or whatever, that it'll cost more. And so there are a few, so you could imagine a few people. So if you're there and you can go to a $35 copay and call someone at American Well or whatever and say, I have this, okay, I've got one right here. I've got this spot. Tell me, do I have, is it flesh-eating bacteria or is it but if you're convinced that the answer is wrong, that one one of them gave you because maybe you call another one and you use it over and over and over. Our experience that telehealth integrated into a system does not cost a system more, but it's these that you can go to anywhere, and it's outside the system where it does end up costing more. So that's Congress's worry, is the idea that they open up the codes for doing these different things and the system costs more. So that's one of the worries. So we need data. So any other thoughts, questions? Yes, sir.
I was curious about the fourth aim and the quadruple aim with regard to this. So do we have data that shows that providers who are participating in ECHO gain benefit, personally feeling empowered or reduced frustration when they participate in this?
How many PowerPoint slide decks do you want in your inbox? Because that's what we have. We have really great data on that relative to that we've changed their capacity to do blank, blank, or blank, and that they actually like it, and then qualitative that this really, so all the qualitative stuff too related to comments. So we have a lot of that. I just don't think it's enough. So anything else with that? Would you like, if there's a topic that you would like to see that in, I'll send it to you this afternoon.
I'll think about it.
Okay. Yes, sir.
So a lot of this is about empowering sort of PCPs and nurse practitioners and PAs to care for more complex patients. How do these providers, how do you justify, like, if you're a nurse practitioner in Idaho Springs, you see 6 kids with asthma, one of them's real bad, and you're frankly happy to have them go down to Children's and take care of that mess. And now it's like, well, you have the capability to take care of them in your clinic. You have the right medications. You just need to participate in this ECHO thing, but you're busy.
Yeah.
How does that value work? Yeah. So
both directions. So not any provider who says, I just want this off my plate, because if it's not an effective use, or if it's like if it's something that is too complicated, they could very well say that's not an appropriate ECHO or e-consult case.
Yeah.
That's the whole idea of the template related to, is this an appropriate thing that we could actually help you learn more? But ideally, as they're learning more of these low and middle and a little bit more difficult to stretch themselves, they're expanding their capacity to do more of that, but in partnership with the ability that they don't go too far. Because it's not meant it's keeping the right patients out of the hospital. So this is a thing too, I'm full of sentence fragments, I apologize. But I'm always talking about keeping people out of the hospital, and then a CFO or somebody will say, hold on there, keeping the right patients out of the hospital. And so we actually also have a paper that gets to that, with the idea that, can you do cases this way in a way where the sensitivity is still high relative to you're not missing anything that could be a problem related to this primary care person managing remotely. And if you do that, and this was a rheumatology paper, if you do that, if you're keeping the right patients out of the hospital with a topic like that, what happens for the revenue stream for the hospital? And so this paper had actually demonstrated that if you're keeping the right people out of the hospital and providing care locally, that the 8 or 9 months of people that are in the queue that need procedures get moved up. And so it actually was a revenue generator for the hospital. So it's like a 9-to-1 revenue generation, along with keeping the right people treated locally. Again, the partnership thing.
That's sort of a second question. If you're a primary care provider, you're going to see a broad range of things. You might not see that many patients with any particular thing that's an ECHO topic.
Yeah.
How do you?
Well, it may be an e-consult. It may be an e-consult thing. So it's like you're using another one of the pieces of the tools. So not necessarily that you're doing ECHO all the time. You're doing a e-consult sort of thing. So you drop in a request to get a feedback about a topic that comes up for you, and that's going to be the only one I see this year.
What's the threshold where providers find the ECHO model more, or the group consult more effective?
Don't know the answer to that. You might have a way to think about that.
So the typical sort of operational limitation of an e-consult is usually, enter these standard things about the patient and ask me your one question. If you have 2 questions, submit 2 e-consults.
Mhm.
And so where Echo tends to shine in that threshold in the clinical space is usually around patients for which there's more than one question, or like I have a follow-up question, or this kid is not just an asthma kid, they also have depression, and I need to be able to talk about this person in a complex way, or I'm probably just going to call you to follow up on whatever you write back to the e-consult, so let's just organize this. Like autism is a classic example, the diagnosis and management of it is a classic example where Echo really shines, because their presentation of that is as various the personalities that come with the diagnosis. So I don't know if that answers your question, but I don't know that there's any formal literature that says this is where a primary care provider makes that choice. But the e-consult operational structure kind of makes it for you.
Okay. Yeah. And again, context, social determinant stuff. So the idea about, because that's a lot that gets missed in the stuff that may happen here too. It's like if you could have something safely locally with someone who knows more about the whole family and everything going on, perhaps that's more efficient. Anne, do you have a question?
Me? No, I was getting ready to sneak out the back.
I know, that's why I called you out. Okay. Yes, ma'am.
It's nice to know the update of your work. And you mentioned about funding seeking. Can you tell us more about this MAT funds? Where was the source? And during the application process and implementation process, what you learned, to design those type of evaluation studies?
Well, that's a lot to unpack there, but I'd say there will always be philanthropic asks, and I think that we're very timely related to some requests that AHRQ, PCORI, other fund, Robert Wood Johnson, other that are thinking of that sort of thing, and the Colorado Health Foundation has given us a whole lot of money, but they also would like to give other people money at this point too. So they're at saying, could you diversify your funding streams? Could you figure out how where more of your money comes from other places? And so as I speak from a braided funding model, that's how do you build yourself into things that you bill for? We also have a system, a learning management system, Connect, that we get some amount of royalties off of too, not a lot, but that's an opportunity to build out as well. And it's just sort of how do you do, and ideally, if this doesn't get funded by federal or state from a reimbursement perspective in the next 2 years, I may be saying a lot of, would you like fries with that? No, I probably won't say that, but I will be doing way more class teaching and way less of this sort of work.
But you mentioned, it seems like you mentioned the MAT.
Yeah, that was funded by AHRQ. It was an AHRQ grant.
Try, right? You mentioned.
It was.
Oh, and can you tell us more about the design? Because
I'll send it to you. Okay. Yeah, but it was a randomized to the learning group, and so by practice. And so before we set it up, there were 40 practices that were randomized to in person and 40 practices that were randomized to Echo, and then went through the work. And then we have all the data from a practice provider. We don't have patient data because, but there are some mechanisms through OppiSafe that we could get patient data too, but that's going to be a little while out. Yes, ma'am.
Hi, my name is Romana Ayala. I'm from the VA. We are currently putting together a grant focused on quadruple aim. And so I wanted to see if you have any evaluation tips in terms of measuring the quadruple aim per project. We have 3 different projects. We're trying to do a cross-project synergy. We're interested in the quadruple aim. But if you have any tips in terms of thinking about outcomes, evaluation metrics, or general recommendations, I would love to hear.
It's interesting too, because we've really worked hard to be partners with the VA relative to how, but we've pulled back some relative to getting data out of the VA system. And so I think that's the first issue is like how can you and are you able to draw data out of it? Because we actually had any number of things that we were loaded up and ready to go with on topics, and I'm sure we're talking probably similar topics, substance abuse and behavioral health in rural communities or complex cares. But if you would like to set a time and meet separately, I'd be more than happy to talk about things that we specifically designed for those, VA or not.
Yeah, that sounds great. And that's a valid point about data out of the VA is really difficult. One way that we're going around that is accessing non-VA care data to sort of matches our patients in-house behind the VA firewall. But we're hoping that the visibility and sort of the black boxness of VA is changing.
Yeah,
So,
I would hope so too.
yeah,
I'd
would
love
set
to
up a
visit with
meeting.
you about it.
Yeah.
Anybody else? Yes, ma'am.
Quick question, are the ECHO sessions archived or are they only really for live participation?
They are archived, and this man right here can tell you more about
They
that.
are really for participants, just to protect the privacy of the learners.
Sure.
They're primarily discussion based. But did you have an interest in observing one, or just you get like a personal interest in seeing what they're like?
Arrange that.
Yeah.
Okay, thank you.
So thank you for coming today, even though food was not served. I really appreciate it. I gave a talk in Breckenridge on Saturday, and it was decidedly off Broadway. So, you know, the conference was Thursday, Friday, and Saturday. I was on Saturday morning at 7:30. And then you're walking toward the conference center, and it's like, oh, Dr. Thomas, you're over here. So you walk down the hall and around the corner, and there's a bathroom and the snack machines and then the little room. And so it was way off Broadway. And so those people, I'm not sure why they came. There was food. Maybe that was it. But, anyway, thank you all for coming.
I just told them.